Hello, everybody. So we are going to be talking about oxygen needs. This is from chapter 39. And a lot of the things that we're going to talk about, we've already talked about really in the respiratory system. So some of the things on that we'll review real quick and then move on to some of the other things that we're going to talk about, and we'll also go through when we meet for class in the lab. So the first thing with oxygen is we know that it is a gas and that it has no taste, odor, color, and its basic need for a requirement for life. We also talked about, when we talked about first aid CPR, that death can occur within minutes if breathing stops. And not only does death occur, but also brain damage and serious illness can occur when there is not enough oxygen that is being pumped to the brain. And the amount of oxygen in the body is affected by illness, surgery, or by injury. And you can assist in the care of persons with oxygen needs. So factors that are affecting oxygen, the respiratory and circulatory systems we know work together in order to properly get oxygen to our cells. And that disease, injury, or surgery involves these systems and affects the intake and the oxygen use. Altered function of any system affects oxygen needs. If the circulatory system is not functioning properly, if the vessels are narrowed, then blood must flow to and from the heart. If it's narrowed, then the oxygen cannot, that exchange can't take place. Red blood cell counts. Red blood cells contain hemoglobin, and it's the hemoglobin that gets the oxygen from our cells, from our lungs into our cells. The nervous system. Diseases and injuries can affect respiratory muscles, making breathing more difficult or impossible. We also know that drugs and other medications can depress the respiratory system, and then therefore can affect the oxygen that is getting up to the brain and the brain function. We've already talked about aging factors that affect the respiratory system, and the fact that the respiratory muscles weaken, and that then we don't have the strength for coughing, and then pneumonia is a great risk. Exercise increases the need for oxygen. Both we need the oxygen, that also increases our respiratory rate, and those two things kind of go together. We talked about back in the preventing infection chapter how fever increases the need for oxygen, and therefore the respiratory rate goes up. Pain, respirations increase in order to meet the needs for oxygen. Drugs, as I said previously, depress the respiratory center in the brain. Smoking, we know, causes lung cancer and also causes chronic obstructive pulmonary disease. Allergies can affect our respiratory system. Severe swelling can close those airways. Pollutants, nutrition, iron and vitamins are needed to produce those red blood cells. And then alcohol in excess reduces the cough reflex and increases the risk for aspiration, can also suppress the nervous system, which, as we talked earlier, can affect the respiratory system. Respiratory function involves three processes. And again, this is just a review of the respiratory system. And then hypoxia means that cells do not get enough oxygen. Okay, a person can be hypoxic. Cells cannot function properly. Anything that affects the respiratory function can cause hypoxia. Early signs of hypoxia are restlessness, dizziness, and disorientation. Hypoxia can threaten life. Normal adult respirations, if you remember back from our vital signs section, are 12 to 20 per minute. Infants and children have faster rates. Normal respirations are, we know, the way we breathe every day, and they're quiet, they're effortless, and they're regular. Both sides of the chest will rise and fall equally. Abnormal breathing, also, if you remember back from the respiratory system and from our vital signs section, that we can have breathing patterns that are abnormal. We can have rapid breathing, tachypnea. Respirations are more than 20 per minute. We can have slow breathing, bradypnea. Respirations are fewer than 12 per minute. We can also have apnea, or the lack or absence of breathing. This occurs in sudden cardiac arrest and respiratory arrest. Hypoventilation, slow, shallow, sometimes irregular, and hyperventilation, respirations are rapid and deeper than normal. We can have dyspnea, difficult, labored, or painful breathing. Cheyne-Stokes respirations, their increase in rate and depth and then become shallow or slow. And again, in our respiratory section, I had demonstrated what some of those respirations might look like. Orthopnea, that means breathing deeply and comfortably only when the person is sitting. Biot's respirations are rapid and deep respirations followed by 10 to 30 seconds of apnea or absence of breathing. And then Kussmaul respirations are often can signal diabetic comas. They're very deep, rapid respirations. Some diagnostic tests that might be ordered by a physician if we recognize any problems with the respiratory system. And one of the most common would be a chest x-ray. Most of you are familiar with a chest x-ray. Lung scans can be done. Bronchoscopies, a little more invasive, where they would, put a tube down someone's throat and see what is going on down in the lungs. And then a thoracentesis would be a puncturing of the lung space. A pulmonary functions test would be completed by the respiratory department, or we can check the arterial blood gases, and those give us an indication of the gases that are in the arterial system. A pulse oximetry test can be completed as well, and you may be asked to do this test, and some of you may have already done that on your rotations. We'll talk about that here in a little bit. They may also need to do a sputum culture, and you can be involved also in collecting that sputum specimen. Always remember that you're involved in reporting any of these observations promptly and accurately, and that some respiratory problems might be acute. They might be sudden, they might be just for a short period of time, and then there are others that might be chronic, and these patients have a history of these problems. Either way, any of these abnormal respiratory observations that you make should be reported to someone immediately so that they can do further investigating and see if some of these diagnostic tests might be needed. Okay, so pulse oximetry. We're going to talk about this in the lab, and everybody will get a chance to use our pulse oximeter if you haven't already. Some of you have already done this out on your rotation sites, but we know that a pulse oximeter measures the oxygen concentration in the arterial blood. The range is 95 to 100%. It's a sensor that attaches onto the finger, the toe, the earlobe, the nose, or the forehead that senses from the arterial blood site and then gives that reading. Some of these sensors, we have the sensor that you'll be using here in the classroom, but we also have sensors that are more of an adhesive, and those are more accurate because they don't move, they move with the person. So if you have a very active individual, you'll still get a good reading. Oxygen concentration is often measured with the vital signs, and then they are reported and recorded according to your agency. And if you could refer to page 646 in your textbook and review those delegation guidelines, so that, again, when we do this in the lab and when you do this out in the clinical setting, you know that if you have been asked to do a pulse oximetry reading, that you know what kind of information you need in order to do that and to get an accurate reading. Meeting oxygen needs. To get enough oxygen, air must move deep into the lungs. It must reach the alveoli where O2 and CO2 are exchanged. We had said earlier that disease, injury, and surgery prevent air from reaching into the alveoli. Pain, immobility, and narcotics interfere with deep breathing and coughing. Secretions can collect in the airways in the lungs, and they then can provide a place for microbes to grow and multiply. Infection then is a threat. We talked about increased risk for pneumonia. The following measures are common in care plans. Positioning. Breathing is easier in the semi-Fowler's and Fowler's positions. You guys might know this. If you position yourself, if you're lying down on your back flat, or if you then turn over onto your stomach, you can test that out for yourselves and know that breathing is easier when you're sitting up. Some patients, as you see in the picture on the slide, sit up but then might need to lean forward. So we're going to use pillows anytime that we need to position patients so they are a little more comfortable. Many times in the home care setting, patients will sit in a recliner chair and they might sleep in that recliner chair. That makes it easier for them to breathe. Deep breathing and coughing. Deep breathing moves air into parts of the lungs, and then coughing can help remove the mucus. Exercises promote oxygen as well. But know, as we talked about before, that pain can be a big factor, because when we take a deep breath and we cough, it can be very painful, and this keeps patients from wanting to do these things on a regular basis. An incentive spirometer. Again, I will show you this in the lab, and you guys will all get a chance to use an incentive spirometer if you haven't done so already. But an incentive spirometer improves lung function, and it does that by moving air deep into the lungs, loosens those secretions, and then promotes that exchange. Okay, so it's as we inhale, we can see it's called spirometry because as you see the dials on the spirometer, patients can keep track of how deep of a breath that they're taking. And then there's a goal guide on the other side, a coach indicator, which tells them whether they are doing this the correct way or not. And that way, atelectasis is prevented or treated. And atelectasis, again, is all of that gunky stuff that is caught down deep into the lungs that can sit down there and grow bacteria and cause an infection. You might ask to assist with oxygen therapy. Know that oxygen is treated as a drug, so a physician will order this oxygen. They'll tell when to give the oxygen, the amount of the oxygen to give, and the device to use. Some people need oxygen continuously, others need it for just symptom relief. So maybe the person is having some chest pain and we're not getting enough oxygen to the heart, and so therefore we can apply some oxygen and help in that. Maybe they're, for whatever reason, having some shortness of breath. We see a lot of times with sports players, football players, that after they've been running out on the field and they're in cold weather, that they need some supplemental oxygen, and they'll take in some of that oxygen before they go back out onto the field. You do not give oxygen, you just help provide safe care to those patients who have oxygen being administered to them. Assisting with oxygen therapy, there are several different oxygen sources. One might be from a wall outlet, and that is the oxygen tubing is hooked up to a canister on the wall. You might also have a person who's got an oxygen tank, and that oxygen tank will be with that